first guideline that was published that concerned liberation from mechanical ventilation appeared in the early 2000s. It was about 2001 where the first publication came out. So it's been 15, 16 years since that last publication was produced. There's been a lot of new information that has been developed over the ensuing years, and it was time to update the previous guideline. We had a collaboration with the American Thoracic Society and the American College of Chest Physicians to develop this new update. There are a variety of strategies that are used to try to liberate patients from mechanical ventilation. Liberation from mechanical ventilation is extremely important because we know that the longer that a person is on mechanical ventilation, the more likely they are to suffer complications. Many physicians use the spontaneous breathing trial in order to determine if patients are ready to come off the mechanical ventilator or not. We have found by reviewing the literature that when someone uses pressure augmentation during the spontaneous breathing trial, this is more predictive of successful liberation and is closely associated with improved outcomes. Patients receiving mechanical ventilation are commonly treated with strong sedatives in order to increase the comfort of the patients and the tolerance of mechanical ventilation. However, the use of sedatives can have untoward effects when trying to liberate patients from mechanical ventilation. The first evidence that we learned about told us that interruptions of sedation every day, or the use of protocols to reduce sedation, improved the time that patients required to come off mechanical ventilation. Liberation from mechanical ventilation is improved by using sedation protocols which help reduce the amount of sedation that patients receive. Patients who are receiving mechanical ventilation and who have passed a spontaneous breathing trial and are candidates for extubation successfully are liberated between 15 and 25% of the time. There are certain specific risk factors that we know that are associated with failed liberation. These include markers such as decreased cough strength, problems with mental status, and increased severity of illness. When patients have these risk factors, they are less likely to successfully be liberated from mechanical ventilation. When patients have passed a spontaneous breathing trial, they should be expeditiously extubated and liberated from mechanical ventilation. The role of the physician then is to make sure that they remain extubated and don't have to be reintubated. What we have learned is that the use of supplemental ventilation and ventilatory modes after extubation may be important in improving outcomes. The use of non-invasive ventilation by mask ventilation or perhaps by high-flow oxygen cannulas may help in preventing reintubation in these critically ill patients.